Thank you, Oyeyemi, for that backgrounder. And to discuss more on the HPV vaccine in Nigeria, let's welcome Dr. Muyi Aino, is the Executive Director, Chief Executive Officer, National Primary Health Care Development Agency. Glad to have you with us on Good Morning Nigeria.
Good morning.
Also here in our studios in Abuja is Professor Bello Abubakar Mohammed, Chief Oncologist, Chief Consultant, Clinical Oncologist, National Hospital, Abuja. He is also visiting research professor, Federal University of Health Sciences, Azare Bauchi State. Welcome to the program, sir.
Thank you for having me, and good morning, Nigerians.
Kinsley.
Yeah, thank you very much, Demola. I think we'll also congratulate Dr. Bello Abubakar Mohammed on this professorship. Professor Bello, congratulations on this. He's a regular guest on Good Morning Nigeria and one of Africa's most respected oncologists. Thank you very much for being part of today's conversation.
Thank you.
Also here with us in the studios is the Chief of Health, UNICEF Nigeria, Dr. Eduardo Salades. Dr. Salades, we're glad to have you on the program this morning.
Thank you very much, and good morning, Nigeria.
Okay. Here in the studios as well is Dr. Ishaq Lawal, is a consultant gynecologist, the Federal Medical Center, Kebbi, that's in Kebbi State, and CEO of Cervical Cancer Nigeria Initiative. Dr. Lawal, we're glad that you are here with us on the program.
Thank you very much. Good morning, Nigeria.
Joining us via Zoom from Bauchi State is Dr. Riwanu Mohammed, Executive Secretary of the Bauchi State Primary Healthcare Development Agency. Dr. Mohammed, good morning and welcome to Good Morning Nigeria. We can't hear you.
Okay. Unmute yourself.
Good morning.
All right,
Okay.
pretty clear now. Demola?
Yeah, gentlemen, you're welcome once again to Good Morning Nigeria. Let me start with Dr. Muyi Aino, the Executive Director, Chief Executive Officer, National Primary Healthcare Development Agency. HPV vaccine has now been launched in Nigeria. How does it feel recording this milestone with you at the helms of affairs?
I think that, thank you very much for that question. I am extremely thrilled, actually, that this is happening at a time that I really just took on that role. This is because the human papillomavirus vaccine introduction has been on for a while. A lot of stakeholders, even in my previous life, I participated trying to do all of the advocacy, the fundraising, and the preparation for this. So for this to happen right now is a reflection of the government's commitment to make available to our population, especially the vulnerable people, life-saving interventions. The launch was on Tuesday, as many of you are aware, and it's happening in phases. So the first phase is in 16 states, 15 states plan FCT really, and we're hearing reports back from the field, you know, that things are happening. So really exciting times, but really just the beginning. You know, ultimately we now need to focus on making sure that the vaccines get to the people that need to get it. It needs to get to the front line. People need to come out and get it. We need to address all the questions that people have and spread the information to the population so that the girls can be protected against cervical cancer. Thank you.
Okay.
All right, now ahead of the flag off of the vaccination program, we had a conversation on Good Morning Nigeria. This was some weeks ago, and a lot of background information was provided. But here we are, it's taking off now, and 15 plus 1 states are being used for the pilot phase of this exercise. But again, for the benefit of our viewers, how big a deal is this, Professor Mohammed?
Bello. Okay.
Bello Mohammed, everybody the same name.
Right. So it's really a big deal. You see, when you look at the statistics of the prevailing cancers in sub-Saharan Africa, especially in women, the first 2 important cancers really are breast cancer and cervical cancer. And cervical cancer, we know, is predominantly as a result of the human papillomavirus. So if you are able to basically eliminate cervical cancer, you would have been able to reduce the women cancers by literally over 30 to 35%. And that's why it's a big deal. And it's one of the few, let me say, cancers, that's cervical cancer, that is preventable. You know, you can actually prevent it, eliminate it completely, you know, because we do know that it is the human papillomavirus that is the culprit. So it's such a big deal. Many other cancers, breast cancer, prostate cancer, you can usually detect them early and treat them early. But this particular cancer is preventable. By getting the vaccine, you are literally preventing it from happening. Okay, and then over time, with the vaccine and screening and treatment of pre-invasive cancers and invasive cancers, you will be able over time to eliminate it completely. And that's why the World Health Organization actually brought out the strategy for the elimination of cervical cancer by 2030. And this is really leapfrogging towards that strategy, achieving that strategy. And I'm so happy that Nigeria really is at the forefront now. And we hope that with time, we should be able to literally immunize all our young girls. You know, I know that the number is relatively small now, but we hope that in the not so distant future, we should be able to, you know, vaccinate up to 60 million young girls across the country.
Okay, you're sure of that? Because when we look at the way, you know, our, especially the people in the rural areas, the way they receive such information, I don't know whether the cultural impact is going to affect the vaccination exercise. What are some of the way you are trying to create awareness to at least persuade, you know, especially those in the rural areas, you know, to accept this? Maybe I can ask Dr. Ishak. We can speak on that.
Yes, thank you very much for that question. It's a concern for us, the attitude or the misinformation around HPV vaccination. For us as advocates, initially before the federal government, National Primary Healthcare Development Agency introduced the vaccine, cost has been an issue. And now that the vaccine is available now, we are concerned, based on experience from other countries, that people might misconstrue, and there's already that going on. HPV vaccine is a unique vaccine. Just like Professor Bello said, cervical cancer is also unique. So it is the uniqueness of the cervical cancer and HPV vaccine that I think is driving this misconception. And it is the responsibility of all well-meaning Nigerians that have the good heart for the young girls and the women to make sure that they come into this campaign and dispel any misinformation or misconception that can come around it.
What are the unique features, if you may?
Okay, he needs to.
I think I now need to answer that question as well.
Oh,
Yes.
okay.
And I do agree with that.
Okay.
Even just first as a parent, I'm a
Yes.
father of 2 daughters in the target age range, and both of them have since received the HPV vaccine even before now. I believe that every parent that has the right information, that understands, or guardian that understands the importance of the vaccine and its relationship to cancer and the benefit that it has on their daughter will not say no to it. So I think the responsibility really is on all of us, but especially the media, to really help disseminate the correct information, you know, to at all levels, but especially to the grassroots. Yesterday, we were aware of some misconception going around. We are trying to respond to it, but I think I want to charge you, our colleagues in the media, that you have a major role to play here in making sure that our communities, the people in the grassroots are empowered with correct information, that would help them to make the right decision. There's nobody who will have a child and would want to deprive them of something that will give them health and improve their livelihoods. So in terms of what we are doing, even before the launch of the vaccine, the agency had invested in a lot of mobilization and sensitization trainings. We engaged through our traditional institutions, through our religious leaders. At the launch on Tuesday, we saw His Eminence the Sultan was there, the President of Cannes was there, and they committed themselves. They made statements, that people take seriously. As we know, there's a lot of credibility that these institutions have amongst all of our people. But the work, like I said earlier, has really just started. And it's on all of us. So it's really about sensitizing people. It's about making sure people have the right information. When people have questions, we should answer them. We will answer them and give them the facts. Thank you.
Okay, you want to chip in something, Doctor?
Yes. In the sense, we have analyzed why these rumors or misconceptions or disinformations they are coming, right?
Okay.
What are the main issues that people put in the table? And there are three main issues. There are concerns about safety, about the side effects, and as well about if it works, about the if it is effective or not. So I would like to highlight that this is the three things that we jointly with the Federal Ministry of Health, NPHCDA, and partners, we are trying to address. Right? The first thing is important to know that the vaccine is safe, has been already launched in more than 100 countries, has been already approved by the major regulatory agencies in the world, the FDA in the US, NAFDAC here in Nigeria, the European Medical Agency, etc. So we know that it's safe. We know that it has been
No
approved.
side effects?
As any vaccine can have side effects, right? We know that any vaccine you can have like a little bit of fever after it's done, swelling, etc. Side effects are normal, are very mild, and this is nothing major. It's important to say that. And as well, that the vaccine works. That's very important. We know that if you get the vaccine, if a young girl get the vaccine, it's going to reduce the likelihood of cancer, cervical cancer, for more than 80%. And this is the purpose. It's very important as well to say that. The vaccine is not for any other purpose. The main purpose is to reduce cancer and HPV transmission. So I think we, UNICEF, as with other partners that we are working on social mobilization and behavior change, this is the message that we are trying to pass. And we are seeing, like, as Dr. Muyi said, like rumors are around, and disinformation and misinformation, misconception. So we need to work, all of us together, at all levels. Okay. Schools, teachers, parents, communities, traditional leaders, religious leaders, influencers, media. And this is why we're here today as well, to share this with the audience.
Okay, thank you.
All right, thank you very much, Dr. Solades. Let's go over to Dr. Rewan Mohammed, who is the Executive Secretary of the Bauchi State Primary Healthcare Development Agency. If it's there, all right, you can see him on the right side of your screen. Now, while we are still on the subject matter of advocacy, Dr. Rewan, I'd just like to remind you that you were not part of that conversation. Some weeks ago, when we had the first part, ahead of the launch of the HPV vaccination program in Nigeria, we had your colleague from Jigawa join us, Executive Secretary of the Primary Healthcare Development Agency. And this same question that we're talking about this morning popped up on that occasion. That namely, how are you driving advocacy in Jigawa? And it explained the multiple levels that the agency was undertaking, and of course also engaging in terms of critical influencers in that particular state, dealing with misconceptions and rumors that might arise to prepare Jigawa once the flag off then takes place. What has been happening in your own location?
Thank you very much for having me. I want to congratulate Nigerians for at least having the opportunity to get this vaccine launched in this country. It's a rare opportunity for our young girls to get vaccinated. I also want to congratulate Dr. Muyi for this appointment as the Executive Director of National Primary Healthcare. We Bauchi State, we realize one of the main reasons why we have problem with this vaccine is the target audience. 9 to 14 years is really the age of the reproductive age. So you may expect that kind of misconception and problem. So we started over 4 months ago. We actually started advocacy and social mobilization group. Technical working group was actually constructed. I'm the chairman of technical working group. And then advocacy and social mobilization group was also created by me. And we started working NX. We realized that we need to get involved our media organization, our traditional rulers and religious leaders. So what we did in this case to disperse this rumor, some of them, the rumor we are already having it during our polio campaign is coming back because of that. And some people are saying, why is it free? And that's why sometimes I told Nigerians and the government that sometimes we need to put some co-payment like we do in insurance. So we started going in every school where we have target audience, both government and private were contacted. We get in contact with NOAA, which go around, government of Bauchi State paid, and then there was an advocacy by UNICEF, which supported, and WHO, where all hand was on deck actually to make sure that this campaign is success in Bauchi State. But unfortunately, the first day, the governor himself has to come in to actually flag up, but in his absence, the Secretary of Government was there to flag up the campaign. And he directed that all the local government chairmen should go ahead and did the same with their wives so that they show visibility at the local government. And they did, even supported by the Bauchi State government itself from the center here. So we really got a lot of support from WHO, UNICEF, and even the NPSC, they provided all the vaccines. We have national monitors around here. So what we did in the essence is to carry out a lot of jingles in different languages. And we actually have to tell them that this vaccine is very safe and effective, and it's for the betterment of our people. We also realized that the schools themselves, as we did our advocacy, they were not fully informed, particularly to the Ministry of Education, Ministry of Women Affairs, and so on. So what we did is the first day of the campaign, we really had a lot of struggle, a lot of problems with some of the schools, particularly both government and private. Many of them rejected the vaccine at the initial stage. So we have to divide ourselves into 3 zones, and we have to go on to discuss with the Ministry of Education to send text messages. I'm telling you, by today, we are targeting 400,000. We have done a lot of vaccination now since after we resolved the hiccup or the teething problem that we started at the initial stage. And we really have to appreciate the Minister of Health and the new Executive Director of National Primary Care for his leadership, because we know him, we know his antecedents, and we know what he can do. So we really have to pray for Nigeria. No, I want to also congratulate the federal government of Nigeria. In the United States of America was the first to actually started the vaccine in 2004. 2006, the United Kingdom took the vaccines. And then we also have Burkina Faso in West Africa, Liberia, Ghana, Benin Republic, Niger, all of them took the vaccine. So we are not even the first. And what informed me, and we are happy with this vaccine, is that the single dose vaccine that has been selected, which is very easy for us than to have a multiple dose, first or second dose or third dose. The single dose has been selected by the federal government, and that is a better way. And by giving that single dose, I think I even told them, by joke, that if anybody want to take anybody to court, I'm ready to go to court for this vaccine. We have a lot of, I showed them a lot, about 4 of my family members, 3 of my family members and a friend had got infected with this, and 2 of them have died. One that we are able to save by removing the uterus, the woman is still alive. So it's practically I've been touched by the kind of the trouble that we face when you have cancer on the service. So we really appreciate the NTA for bringing this to fore and inform the public that this vaccine is safe, effective, and ready to use. Thank you very much.
Yeah, thank you, Dr. Mohammed, for your contribution there. Now, back to the studio. Let me ask Dr. one more time. This is the first phase of the launch, 16 states and the FCT. How soon are you planning to reach out to other states in the country?
So the first 16 states kicked off this week, and the plan is to go to the remaining 21 states in the second quarter of next year, around May. That's driven by a couple of factors. This is the first time that we're introducing a vaccine targeting this age range. Almost all of the other vaccines that we have really targets young children that our system and our health workers and people are now very familiar with how to reach them and how to really interact with them. But there's a lot of learning that we need to do as a country, as we deliver this. So we want to learn and be able to use those lessons to expand to the other states. The second thing is also that the vaccine is in demand. It is constrained in terms of its supply. So we can only get access to so much, so we're going at the pace that we can use what we are going to get. But to answer your question, May 2024 is when we plan to go to the rest of the states.
Now, Dr. Salat, I just want to ask this question. The vaccine will be administered to girls within the age of 9 to 16. What about, someone with 26, 27, up to 30, can they also benefit from it?
So
are they out of the circle totally?
So thank you very much for that question. So here, as Dr. Muji was mentioning, the vaccines are going to be available for girls from 9 to 14 years old.
9 to 14.
For free, completely for free in any public health facility in 16 states now, and in May next year in the other states of the federation. The specification of the vaccine say that young girls until 25 years old, they can get the vaccine. But the batch that we have here in Nigeria, they are offered for free, that has been supported, that the Federal Ministry of Health is introducing, supported by UNICEF, that we are doing the supplies, but with Gavi, with the funding, the NPHCD, etc. It's only for this age range. Why is that? In public health, we need to prioritize, right? Okay. Basically, we have the burden of disease, let's say malaria, diarrhea, pneumonia, cervical cancer, etc., and the resources are limited. There are some countries, for example, that they offer the vaccine even to boys, even they don't suffer cervical cancer, but they are carriers, right? But some choices need to be made, how to use best our resources. And the decision that the country made, we believe, has been quite smart. One is having one single dose of the vaccine. The second one has been to prioritize the girls where this can be more effective. So we really believe this is the way forward. And of course, if one day here we have many competing priorities, right? Maybe in next year or soon, malaria vaccine will be available. The country introduced rotavirus vaccine last year. So it's about making choices, making decisions that they have an impact. It's very important to say that this vaccine, Dr. Moji was saying, is addressing young girls. And this is actually a fantastic entry point to look into adolescent health, right? We know that a teenage pregnancy, for example, is rampant in many places of the country. We know early marriage as well. So this is really a way to start to work with the young girls in their own health, right? So they empower themselves. They have the voice, the agency to really starting to have a healthy life ahead and being a productive member of the society.
So how many doses is required for?
So at this moment, for this phase of the campaign, we have about a little bit more than 6 million doses of vaccines. It's going to be one single shot.
Okay, one single shot.
And
okay, just one. One for all.
Yeah, yes. one works. And then from now up to May, we'll have in country 15 million doses. So the Moji says there is not a global shortage. There is a lot of demand for this vaccine. So Nigeria has been fighting hard to get the doses needed. Big population, a lot of girls, but Nigeria, as usual, got it, and 50 million doses of vaccines have been allocated.
All right, thank you very much, Dr. Salades. Let's bring in again Professor Bello. Professor Bello, why the focus on age 9 to 14?
So we know that the human papillomavirus is sexually acquired, basically. So that age bracket is presumed that this is before sexual debut. So they are not exposed to the virus, because the vaccine is prophylactic vaccine. It's not a therapeutic vaccine. So in other words, what that means is that if somebody is already exposed to the virus, the vaccine is not going to likely cure him, right? It's not going to. So, and we do know that the main culprit are the HPV 16 and 18, right? And so if one is already exposed sexually to one of the viruses and you receive the vaccine, it may target the one that you are not exposed to, but it's not likely going to protect you from the one that you are already exposed to. And that is why that age bracket is very critical. Okay, so from 9 to 14 is assumed, so that, from studies and so on and so forth, that they have not been readily exposed to any sexual intercourse, and that prevents it. And now, you ask that question, so why that age bracket? Can't somebody that is 26, 40, and so on get the vaccine? Yes, there are processes that you can actually receive the vaccine. But when you are talking about the national primary health care, the national immunization, which is free, they want to target this bracket so that they are not even exposed to the virus. But if you have been probably you are age 40 and then you still feel that you want to receive the vaccine, there are processes. You need to do screening and make sure that you are not exposed to the virus before you are eligible to receive the vaccine. So that way you are absolutely sure that there is no exposure already and you can actually receive the virus, but not within the context of the national immunization program.
I just to re-emphasize the point you just made, because I'm remembering now, a director in the primary healthcare agency, national, Dr. Basi Oposon, who was one of our guests, did say that the focus on 9 to 14 derived from data produced by the National Bureau of Statistics. Right. So that's the age before exposure to intimate acts that could then lead to. But there's a question that is, it should be curious. Cancer wasn't always regarded, at least in the popular thinking, as an infectious disease. Is cancer an infectious disease? But it appears that cervical cancer, from what you are saying, is it an infectious cancer?
So there are cancers that are as a result of infection.
Okay.
In fact, in sub-Saharan Africa, about 40% of our cancers are as a result of infections, mostly viral infections. If you look at the liver cancer, is as a result of the infection with the hepatitis B and C virus. Some head and neck cancers are as a result of the Epstein virus and the human papillomavirus. And then, of course, gastric cancer as a result of the Helicobacter pylori, and then bladder cancer as a result of schistosomiasis and so on. So there are some cancers that we know are caused by viruses and, in fact, some bacteria as well. But other cancers are not really as a result. Prostate cancer, we have not been able to pinpoint any infection yet. Probably there may be even the human papillomavirus as a culprit. A lot of studies are going on to really see why Africans develop a lot of prostate cancers beside the high level of testosterone and other genetic predispositions. So that is also going on. But like I mentioned earlier, the human papillomavirus is the real culprit of the cervical cancer. And it is not only cervical cancer that the human papillomavirus causes. There are so many other cancers, oropharyngeal cancers, and so on, head and neck cancers, and so on and so forth. And not only cancers, it also predisposes to other diseases like the genital warts, and so on and so forth. So the vaccine that is being used, which is the quadrivalent vaccine, targets not only the subtype of the human papillomavirus that causes just cervical cancer, but also other diseases as well. So it's such a fantastic thing.
Okay, thank you very much, Professor Bello, for your contribution there. Let me direct the next questions to Dr. Ishak, being a gynecologist and obstetrician. Does this vaccine, does it affect fertility in women, or pregnancy?
Yeah.
Does it have any effect at all? Because that's one of the fears that women are raising and all that.
Yeah, to answer that question straight, it does not. Now, but before I proceed on that discussion, when I was opening, I mentioned the uniqueness of HPV, uniqueness of cervical cancer, and that is the whole basis of all this misconception. HPV infection is acquired at teenage and it progresses to cervical cancer in the woman. It then means to prevent cervical cancer in a woman, you vaccinate a girl. That process, Nigerians and the world, because this misconception is not only happening in Nigeria, that process is difficult for people to comprehend because most of the vaccines we have are targeted at a disease at a particular point in time. You give polio vaccine to prevent somebody from having polio. We are not giving HPV vaccine to prevent HPV infection. That's not the target. Yes, it's going to prevent HPV infection, but the target is that it's going to prevent development of cervical cancer. And until we properly situate our discussion, we're going to continue to have this misconception around it. So we should, I'm going to be employ all the advocates to start using cervical cancer vaccine. That is what HPV vaccine is for. Not to prevent HPV, but cervical cancer. Because whether you give the HPV vaccine or not, HPV infection will likely, person will have it. The uniqueness of HPV is that when you have the HPV infection, the body's natural immunity takes care of it, prevents it from being integrated into the system. It is those that get integrated into the system that progress to cervical cancer. Unfortunately, we don't have any barometer to measure those that will progress, those that we integrate. So what the vaccine truly does is not that it's preventing HPV infection. It is preventing, it's already sensitized the immune system of the person so that when the HPV vaccine, when the infection comes, because 99% of women will eventually have this infection, but they will clear it without any effort. Only about 10% will then progress, and those are the ones. So this vaccine, when you have already exposed the body to the vaccine, you have already built, it's like building the armor, the army of the body of a nation in preparation for a war. So when the HPV infection eventually comes, the vaccine, the body immune system is already ready. It hits it, it does not allow you to integrate, it does not allow you to progress.
So in plain language, for the benefit of our viewers, as Dr. Ishaq Lawal is saying, the HPV vaccine is not intended to prevent the acquisition or you contracting HPV, but to prevent the HPV, when you do contract it, from progressing to cervical cancer. Is that correct?
Yes.
Yes. All right.
So we should be using it as cervical cancer vaccine. So it does not have the infertility that is there.
It does
not affect any reproductive function.
Okay.
It is just because of that misconception, because of the age group that is being given, that some unscrupulous elements are beginning to link it. There's no fact to it.
Okay, let's bring in the CEO of the National Primary Healthcare Development Agency to weigh in here again, because we are looking for a one-liner that can help drive the advocacy and then deal with the misconception. So you have heard Dr. Lawal. Let's get your own perspective on this, whether you are reinforcing or tweaking it, but more importantly, what are those misconceptions that you've heard about? Is sterilization one of them, and how do you address it?
So a number of things. Thank you very much for the question. I think to the extent that we position the HPV vaccine as a cervical cancer prevention vaccine, I think that is correct. I think I'm aligned with that. I think people can relate. Where I would like to tweak it a little bit is that while it does not prevent exposure, what it does is also prevents the infection from taking hold in the body. That's what every vaccine does. So it in fact does protect against the infection, you know, in some regard. And then if the infection does not take hold, then it does not progress to cancer. But Dr. Ishaq is right in the sense that ultimately, as of today, if you know, the data shows that adults in Nigeria, somewhere between 40 and 70% are already carrying the virus, depending on which part of the country you're looking at. And most people will not progress to cancer. However, you do not know those that will progress to cancer. 12,000 of us of our women progress to cervical cancer every year. Say 8,000 of them die every year. So you don't know who these ones will be. So that's the importance of the vaccine. Just wanted to clarify that a little bit. To your point around what are the misconceptions, there are misconceptions. A lot of them are around fertility, that this is really targeted at, controlling fertility around a certain age of people. There are misconceptions around the motives of the people behind this, why is it free? It's important to clarify that these vaccines did not come free. They are in fact expensive. They have just been paid for by the government and its partners, Gavi and others. So it's been paid for. Does not mean it came free from somebody. No, the government bought it because the government has interest in making these life-saving interventions available to people. And the conversation around does it affect fertility, I think that's already been addressed. The simple and clear answer is no. There is simply no evidence, that this is linked to anything to do with fertility. Of course, a lot of people, and that's expected, a lot of folks who are not as well informed will say many things. I think, like I said earlier, it's important that we use every opportunity to clarify and provide the right information to stakeholders, and that is why we are here.
Thank you for your contribution there, Dr. Let me go to Dr. Sellers. This HPV, where does it come from? Is it as a result of our environment or the style of living? Where does it come from?
Well, HPV and the different types, there are like many types of HPV. There are more than 100 subtypes, right? This vaccine prevents the 4 major types, like 16 and others, right? And viruses are all around us, and they have different transmission modes, right? We know, for example, some virus like COVID, so droplets, transmission, etc. In this case, it's a virus that is mostly sexually transmitted, and has been with human beings forever, let's say. Now we have the tools, we have the experience, the data, the evidence that we know how it's transmitted and the consequences of it, right? That previously we didn't know. Professor Bello was mentioning that now we know that many cancers, for example, came from virus. So we have been learning. We have been learning about virology has been one of the, in the last 10, 20 years, one of the areas of medicine that has progressed more. Now we have a lot of evidence about how many viruses have consequences in our daily lives, right? So we need to acknowledge that the virus is with us, is going to continue with us, but we need to acknowledge that we have the best tool to prevent it, that this is a vaccine that now is available. And that's the good news that we have.
Dr. Solares, I still want to stay with you. I would like to imagine that UNICEF would have gained experience in overcoming obstacles to effective advocacy on account of misconceptions around some forms of vaccines, including perhaps the HPV in other jurisdictions. How was this done?
Very good question, thank you. And I would like to start saying, if we already know, we don't learn, right? So sometimes as well we need to acknowledge that we are always learning, and there is some things that we need to learn. There are 3 main challenges, we believe, regarding the long-term sustainability of the HPV vaccination in one country. The first one is regarding the delivery platforms. For example, here in Nigeria, we have many girls out of schools. And this is something that is very important to us. Because in the schools, we can reach them. It's just to go to the school and to vaccinate the girls. But what happens with the girls that they are out of school? So what we learned was like we need to be working with the communities through community dialogues, through stakeholder engagement at community level, traditional and religious leaders, and the grassroots, right? Both at the high level, but as well at community level. The second challenge that we are seeing in many countries is the routinization of the vaccine. Let's say, now we believe that we're going to have a very successful campaign, right? We have the resources, the leadership, we are here today in TV, but what happens in 1 year from now, right? The parents, are they going to remember that when they have like a 10 years old daughter, they need to go to a health facility to get the vaccine. That's a challenge that we are seeing in many countries. The first year of introduction, we see a very high coverage, 80%, 90%, really very good. What we see is like the second year, the third year, once you stop the campaigns, what we see is that the coverage decreases. People forget that they have you remember that you have a baby, that you need to go to the health facility 6 weeks, just after birth, 1 month, 2 months. But do you remember that you need to go with your teenage girl to get the vaccine? So this is a challenge. And this is something that we are working with MPH CDA and the Federal Ministry of Health and partners to see how we can ensure the intake over time. And the third challenge you already mentioned is vaccine hesitance, misinformation, rumors. As well, this has been very damaging in many countries if you don't do the right things that we believe here we are doing. And especially this engagement. It's engagement with traditional religious leaders, communities, influencers. We are seeing these influencers in Instagram, in Facebook, saying these infertility rumors and things like that. So as well, having a coalition of media, of practitioners, of government, of partners, of NGOs to really address that, we believe is key. But as I said, if you already know, you don't learn. So let's keep learning.
Thank you, Dr. Sellet, for that. Let me come to Professor Bello. Why did it take so long for Nigeria to start to launch this vaccine? Going by the fact that Rwanda, they have launched theirs long ago, and since with South Africa, Seychelles, why did it take so long for Nigeria to launch it?
Well, maybe probably it would have been.
Oh, okay.
But I will still, I think,
Okay,
a little bit of knowledge, but he has probably a better knowledge. But let me hasten to say that the vaccine is really in demand, in high demand.
Oh, okay.
And there's a lot of competition.
Okay.
You know, and the Gavi, that the organization that is probably the global organization, you know, Gavi is Global Alliance for Vaccine and Immunization, as the one that actually provide most of the vaccines, you know, has a lot of challenge in terms of production because of demands. You know, high-income countries pay a lot more as compared to low-income countries such as Nigeria, so it's highly subsidized. Rwanda is just 14 million people, you know. And Nigeria, you know, we are looking at getting 60 million doses, you know. I mean, in Rwanda, out of the 14 million, how many are actually going to be immunized? So very few, you know. So it's easier for them to really get the vaccines, you know. And you cannot just buy, say, 50,000 vaccines and say, let me start it from Kano, for example. Others will start shouting. I mean, we know the politics in Nigeria. It has to go all over the country. So a lot of work has been done. You know, this really, I remember vividly we were in a meeting with the National Primary Healthcare Development Agency in 2019, and we were hopeful at that time that it was going to be launched that same year, 2019. And COVID came, you know, and literally took over all the money that they have saved for that vaccine and so on and so forth. So it's really a lot of work to even get it done now. You know, a lot of work that has happened behind, you know, the scene to really get these vaccines here. It's not a small thing, and I want to believe that if the executive director of the National Primary Healthcare Development Agency will tell you the process that went through, it will take the whole of this program.
Okay,
So
Dr.
Wee,
you have more to add to it.
Ademola, let's pause. Let's pause in the meantime. It looks like. All right, you're welcome back. Now let's rejoin our guest, who's the Executive Secretary of the Bauchi State Primary Healthcare Development Agency, Dr. Rilwan Mohammed. He's been with us, of course, via Zoom. Dr. Rilwan Mohammed, is Bauchi one of the pilot states? And if so, how many doses of the vaccine has the state received? And what has been the experience with the rollout, particularly with issues around the misconceptions that the other guests have been seeking to address here with us in the studios?
Thank you very much. We received actually around 400,000 doses of vaccine from National Primary Healthcare, and we distributed accordingly to the local government. And then one of the things that I wanted to say, which is the issue of 9 to 14 years, because of the quantity of vaccines were not available since 2012, 2015, 2019. I was the executive secretary of FCT Primary Care for 8 years, and we are expecting this vaccine to be available, but it of the Federation that this vaccine was introduced because of highest teenage pregnancy and early sexual default. Because we have also dropout rate who are actually after dropout rate of most of the ladies, they are married out. So Bochise was very strategy in, we are really happy about this vaccine. And then the misconception, if you look at the misconception, it's really a big challenge to us initially, but we overcome it by involving the Christian Association of Nigeria Bauchi branch and the JNI of Bauchi.
It looks like Demola, yes, we are losing the audio from
okay, I
from
think
him.
we have lost him. So let's come back to studio here where we still have our guest. Dr. Mui, you were going to speak more on why Nigeria is just launching the HPV vaccine.
Yes, like has been mentioned, several countries have earlier launched the vaccine, and if you look at it, in fact, Nigeria started the process in 2015. We started trying to introduce the vaccine since 2015, but like Professor Bilu said, there are a number of things. One of the things is that it's a costly vaccine. It's also not enough to go around the demand in the world. We have a very large population. So basically coming up with the resources, but also in the way that we're sure that the vaccine will be properly utilized took a little bit of time. Also, as Federal Ministry of Health and MPHCDA, we were quite busy in some other introductions. So the rotavirus vaccine was recently introduced, and like again Professor Bilu said, right before the HPV, the trigger was pulled, the COVID struck, and then we went through the process of introducing a new vaccine, which was the COVID vaccine, you know. So if you're going to do it effectively, you have to do it carefully, you know. So those are some of the things that delayed it. But I think now that we have introduced it, it's still very timely. I think children are always being born. Our children are always getting into those cohorts, and it's really making sure that now that we are here, we need to maximize the impact of the intervention. We need to speak to the communities, we need to speak to our schools, we need to reach our out-of-school children. Thank you.
Thank you very much for that contribution there. Okay, Professor Bello, let me just ask this question. The HPV virus, whatever, is it only cervical cancer that it causes? Does it cause does it bring out any other issue besides cervical cancer?
Yes, so you know there are different types of the human papilloma virus vaccine, and like the other speaker that was here with us was mentioning that we have over 100 of the subtypes, but we've been able to find out that few of them are the ones that cause different type of diseases. Some are pre-invasive, some are not even cancerous. You know, the genital wart is also as a result of that. You know, and there are oropharyngeal cancers, that is cancers around the mouth, and so on and so forth. So some of the vaccines only prevent or target those viruses that causes cervical cancer. So if you have, there's a vaccine called the Cervirex. It targets only 2 of those subtypes of the human papilloma virus, the 16 and the 18, that are the main culprits for causing the cervical cancer. And you have the Gardasil, that is 2 types. There is the quadrivalent, the one that that means it targets 4 of the subtypes. And then you have the nanovalent. The nanovalent is the one that targets about 9 of the subtypes, right? So those 9 subtypes cause different types of diseases, not necessarily just cervical cancer. So there are different types, and there are different infections that the human papilloma virus can cause.
All right,
but the main concerns, the main primary problem we have in this country is cervical cancer, and indeed around the world.
Well, okay. Professor Bello, thank you very much. I was just wondering, back to the studio. I was going to go to Bochi again, but we understand that the Zoom uplink isn't just quite tidy yet. So whenever that is done, we'll come back to the studios. So we'll go back to him. Now, Dr. Lawal, you heard Celades, the Chief of Health of UNICEF in Nigeria, share with us experience from other jurisdictions that at the launch stage, usually the first year, the coverage is no less than 80%, sometimes ramped up to 90%. But thereafter, you begin to find a plunge because people forget, and according to him, there is no routinization of the vaccines for people to get their persons on. How can we avoid that in our own space, knowing that this is what has happened elsewhere?
Thank you very much. If you look at even what started, catalyzed the whole process, then I believe that the stakeholders will galvanize and will continue to improve. Now, what started this? In 2018, the Director General of WHO, having observed that there's this disparity between cervical cancer in low resource settings and developed countries. Currently, cervical cancer is still a death sentence in Nigeria and low resource settings, whereas it's completely preventable and just like hypertension in developed countries. So made a call for global collaboration to end cervical cancer, to eliminate cervical cancer. And that was what led in 2020 to the launching of the global strategy to accelerate elimination of cervical cancer. Based on evidence, based on research, 3 things were said that if we want to achieve the cervical cancer elimination, we need to achieve 3 things. Vaccination of 90% of our girls between the ages of 9 to 14. And as all speakers have alluded to, it's not as if it is restricted to that age group, but the best buy, public health-wise speaking, the best buy is to target that 9 to 14 because there's limited resources for unlimited development. So you then need to judiciously use the available resources. Then screening of the women, 70% achieving that coverage, then 90% treatment of all screen positive. If we are able to achieve this by 2030 and sustain it, then by the end of the century, we will be eliminating cervical cancer. So based on that, stakeholders are coming together and begin to interrogate the challenges. Hence, I believe that we'll continue to improve rather than the coverage nosediving. We have learned from other countries, and of course, with the help and support of the Primary Healthcare Development Agency, and with the energy that Dr. Muyi is bringing from his previous experience, I believe that Nigeria will prevent that experience that has happened in other countries. And I believe I can vouch for what's going to happen with the Primary Healthcare Development Agency based on that.
Thank you, Dr. Ishaq Lawa. We understand that Dr. Rewan Mohammed's Zoom connection is back. Dr. Rewan, we lost you at some point. You were trying to explain the rollout of the vaccination exercise. You said you got some 400,000 vaccines. How are you dealing with the cold chain issue? And then what is the coverage that you intend to achieve at this pilot phase? When are you expecting the next set of supplies? That you were trying to explain issues around that. But now that we are still with you, I'd like you to also respond to what the UNICEF Chief of Health said, that, look, enthusiasm is pretty high at the launch stage, usually also in the first year. After that, it begins to plunge. How do you intend to cope with that when matters are not getting traction the way they ought to?
Okay, I think the network went up, and I'm sorry, I have to apologize for that. And I said 19 to 14 years were selected because of the quantity of vaccines also. It's one of the reasons why, because the quantity of vaccine is being brought by Gavi, and there are a lot of competing demand, as many people have said, like Professor Bello has already mentioned. Now, one thing that we are sure is that the sort of the hiccup that we actually receive from the community, we wanted to design a process whereby we involved religious leaders, because people listen to religious leaders more than ordinary people. So Christian Association of Nigeria Bauchi branch were involved. There are sermons on Sundays, and in even Juma and mosques, Malams were giving sermons about the issue of HPV and the importance of it, and then that it's safe and free. Now, the advocacy core group in Bauchi State, in which I was the chair, I have co-chair, which is another religious leader, were activated. Islamia school were contacted. The federal government has designed a timetable. The timetable is that 2023. 2023 is actually 16 states, and then 2024 we have another 21 states, while 2025 we want to introduce this vaccine into our routine immunization. And then we also discussed during our training and others about adverse reaction following immunization. We asked and we usually investigated. We found out that there was no reaction, but still we bought some. WHO actually supported us. We bought some advocacy kits to make sure that anybody get reaction is being taken care of. Doctors were trained, the healthcare workers were trained. We provide them with hydrocortisone and adrenaline to the doctors. Now, where we are worried is that there are always a negativity. So we now personally have a 10-man group that goes out to anywhere where we have problems. But since the first hiccup that we received from the community, the lack of good communication, people are accepting. Now, WHO and UNICEF have decided that, look, let's carry out a survey after some time. Are you hearing me? No, the flag off ceremony is supposed to be on 25th of September. But with the coming of the Honorable Minister of Health, realized that there's need to carry out more advocacy, and advocacy group should be activated. Most of our advocacy group is still supported by UNICEF, and on the other side is supported by WHO and the state government. Now it was shifted to this yesterday, 24th of April, so that we have time to go on and discuss with people. So we carry out survey within this period to find out what was the knowledge of them, of the community, about the issue of HIV introduction in Nigeria. Only 46% of them are aware of, after we have done a lot of work, only 46% of them are aware that we are doing introducing the vaccine on the 24th of this month. And then when we now go on to ask about they agree to take the vaccine, we now got 96% coverage. So we are really on the safe hand, and we are really happy about that. And one thing that we also need to discuss about is the prevention of cancer of the cervix. One of them is the vaccination. The second one is the pap smear, which we have to inform our ladies from 25 to 30 years to please twice in a year to go and carry out the pap smear. That's how we discover some people in Bauchi, and when I was in Abuja, we discovered many people that are having carcinoma in situ, and it has not gone to the stage 1, stage 2, and stage 4. So we are able to take and handle by removing the cervix itself, and many women are safe. The multiple sexual partners is, as people has mentioned, is one of the culprits. And then early sexual development, and the use of concoction. But our women are really bad. They are using concoction to make them sweet during the sexual intercourse. And those concoctions can predispose them to CS service. And that's another thing that is done. The weakened immune system is another thing that's actually giving us concern. And then we told them during our training and our healthcare workers is that there are contradictions to this vaccine. Number one is those that are pregnant are not allowed to take this vaccine. And then those that are febrile illness, allergy reaction, and previous reaction, we really mentioned to them that there's need for us to avoid that and to make sure that that is done. We really appreciate NTA. You are really giving information to public. Thank you very much.
Thank you, Dr. Rilwan, for that contributions there. Let's come back to the studio here. And Dr. Mui, I just want to ask you two questions. Number one, after this vaccination, is it a one-off thing that the person that is vaccinated, does the person still have to go for regular checkup to check whether it has cervical cancer or not? Then besides the vaccine, what other method or what other things are you advising people to do to boost their immunity against cervical cancer?
Thank you very much for the question. The Gardasil vaccine that Nigeria is using is 97% effective against the cancer-causing strains of the virus, type 16 and type 18. It's a one-off intervention. The thing is, you don't know who the 3% is, so we still advise people to still take precautions, you know. So there are, first of all, there are many women who have already passed the age, so they need to continue to screen themselves, and so that it can be picked early, you know, if they already have some sort of exposure, and then they can be treated definitively. But for the girls who are able to take it on time, I think many of them can be assumed to be covered. And then in terms of other interventions, of course, as has been said, it's a sexually transmitted infection that causes this cancer. So safe sexual practices, delayed sexual debut, other means of protection, the use of reproductive health options like condoms and things also protect against it like every other sexually transmitted infection. And then we then tell people who did not get a chance to get the vaccine or who are beyond the age to say, look, you need to screen yourself, you need to, protect yourself. Yes.
Okay, thank you, Dr. Aino. Professor Bello, now, there is no lottery to determine who is going to develop cervical cancer upon contracting the virus. That's the HPV, as it is said. So a person says, no, listen, I won't take this vaccine. And the person then gets down, unfortunately, with cervical cancer. How costly is the management of cervical cancer?
Thank you, Kingsley. I think in our previous discussions here, we have really tackled some of this cost and even this thing. But let me quickly say that the management of invasive cervical cancer is very, very expensive, beyond the reach of an average Nigerian, because the process is so much. If you are looking at, you want to undergo surgery, and some people after that will still require radiation, some will require even chemotherapy and so on. And you see, sometimes even when you have the money, accessibility to treatment is so limited in our environment, because majority of the advanced stages of cervical cancer, the ones that present, we've said it here, that about 86% of our cancers present very late at stage 3 and stage 4, and that includes cervical cancer. They will require a form of radiation therapy. Now, a country like Nigeria, with a population of over 200 million, will require a minimum of 200 radiotherapy machines. We have just 9 that are functional today. And I know government is trying, it's making a lot of efforts to provide them. They are not so cheap. A single radiotherapy equipment and all the other things will cost about, we've been told yesterday at our meeting, cost about 5.3 billion naira as of today. So it's not so cheap. It's not something that you just wake up one day and say, I'm going to provide it. So you can imagine some people even have the money, but they don't have anywhere to go to. And even in those places, if you go to the National Hospital, I will want people to be visiting hospitals so that they will see the enormity of the problem. You see, we have 2 radiotherapy machines at the National Hospital, and the standard is to treat 35 patients per day on a machine. But we end up treating 100 patients every day on a machine. And that is why you have issues of breaking down and so on and so forth. So even if you can afford it, availability is such a very big deal. And we know that Nigeria, they said 69–70% live on less than $1 a day. And if you have to cough out 1 million, 1.2 million for radiation alone, I mean, you haven't eaten yet, right? So it is really expensive, and a lot of people can't actually afford the treatment. So prevention in this place is really, really better than cure.
All right, Demola, I think we'll have to appreciate our guests. Yes, our guests who've been with us for today's conversation, and we do hope we benefited from the interaction. We were joined via Zoom from Bauchi by the Executive Secretary of the Bauchi State Primary Healthcare Development Agency, Dr. Rwanu Mohammed. Dr. Rwanu Mohammed, big thanks for being with us. Here in the studios, we had Dr. Ishaq Lawal, a consultant gynecologist, the Federal Medical Center in Kebbi, and also CEO and Cervical Cancer Nigeria Initiative. Dr. Lawal, big thanks for being here. Earlier, of course, we also had as part of the conversation Dr. Eduardo Saladas, Chief of Health, UNICEF Nigeria. Professor Bello Abubakar Mohammed, Chief Consultant Clinical Oncologist at the National Hospital Abuja. He's now visiting Research Professor at the Federal University of Health Sciences, Azare in Bauchi State. Professor Bello, once again, congratulations and thanks for having been our guest. The new HEMSman, CEO of the National Primary Healthcare Development Agency, Dr. Mui, I know. Thank you also for being around for today's conversation.
Thank you very much.
Congratulations.
Thank you very much. It was my pleasure to be here.
All right, so that's it for us on Good Morning Nigeria today. Thank you. Tomorrow is another day, same time, 7 o'clock in the morning. Until then, look after yourselves. I'm Kingsley Osadolo.
And I am Ademola Ade. Do have a fabulous weekend.